Alrighty. Hello, everyone. I think everyone or close to everyone in this room has met me or knows me in some way or form. I have been very, very lucky to work with a lot of you that's in this room, connect with a lot of you, and really just be able to grow in advocacy, but grow in this profession as well. So a little bit about me, but I'm a nurse by trade, and I've been a nurse for 10 years. And I started out in an allergy clinic, and I really love allergy, like down to the nuts and bolts, and that's just my favorite place to be. I've done some infectious disease, I worked in an ICU for a little bit, but allergy is my home. And so in the respiratory space, I've been able to branch out as a consultant. I've done a little derm, I've done some ENT, some pulmonary, but it all comes back to biologics. The talks today, there's 3 of them. This first one is on medication access basics. Thank you guys for being here. There's me again. I have to disclose to you, I'm a licensed practical nurse. I'm a certified professional coder. I'm a prior authorization certified specialist, as well as a board certified patient advocate. A lot of alphabet soup there. I do have a day job. I'm the CEO of Medico CX, which is a purchasing agent in the allergy and respiratory space. So I still work with physicians, just not so much in my scrubs in a clinic every day. I'm also the president of NAMAPA. You may have seen some pictures or some logos around here, and that is our 501c3 nonprofit, the National Association of Medication Access and Patient Advocacy. So all the wonderful things you're learning here and through this conference, I get to do 365 days a year through that organization. Disclosure, I have nothing to disclose. I'm a free agent on the market. So quick description about this course. Each step of the adjudication process is equally important and can cause disruptions if not completed correctly. An advocate is suited to help patients navigate healthcare to obtain medications. Join this course to review and implement best practices for navigating and accessing medications for patients before treatment, after treatment, and all the time in between. Some learning objectives. Describe the different types of insurance requested reviews. Discuss how utilization management can assist. Examine a prescription claim and ensure appropriate information. EOBs and how to read them. And then identify prescription claims that require appends or appeals. Can you beat my time? So this is interactive. What is the longest amount of time you've been on hold waiting to speak with a payer or authorization department? My longest, and I have a screenshot to prove this, is 2 hours and 48 minutes. Who can beat my time? What you got? Whew. Which payer? That's a long time. Anybody close? Anybody over the 2 hour mark? I really was hoping there was like a whole bunch of people who beat that time because I was like, it's kind of weak, but all right. So two major differences out there, right? You've got advocates and you've got authorizers. And really what it comes down to is heart, right? And passion. And there is nothing wrong with being an authorizer, and there's nothing wrong with being an advocate. It's kind of hard to define, right? We just say advocate is kind of a broad term. Look it up in the dictionary, someone who's passionate about a cause. But it's ultimately, in our roles, someone who goes above and beyond, right? They go to sleep at night, they're thinking about that auth they didn't get to. They're thinking about that EOB that had a denial and they don't know why. They don't ever just put it down. An authorizer, which again is perfectly fine, knows the process and executes as such, very skilled in this space, but they do their job, they do it well, and that's all it is for them. And they're happy with that. I have many members on my team. They are fantastic at what they do, but they're not crying that a patient's auth got denied. They're not having that kind of bleeding heart, as we call it. Everybody's different, but you need a balance of both to get things done. My passionate person on the phone is going to tell you about your sister's, brother's, cousin's chicken who died and how they need this drug and their BFFs with the rep by the time they're done. The other one is 5 minutes in and out. Here's my J-code, need it approved. Utilization management, kind of a broad term out there, right? When you call a payer, you're calling to talk to you. I need to do a prior auth. Who do I talk to? Sometimes it's the utilization management department. Sometimes it's the pharmacy. Sometimes it's the authorization department. But then my favorite is when you get to the auth department and they're like, oh, you need a pre-D. Where's your pre-D department? Don't have one yet. So there's a committee on utilization management by third parties, Institute of Medicine's from 1989. a set of techniques used by or on behalf of purchasers of healthcare benefits to manage healthcare costs by influencing patient care decision-making through case-by-case assessments of the appropriateness of care prior to its provision. 1989. I'm not going to tell y'all when I was born, but that was a while ago. So pros, it's cost effective, right? We're looking at healthcare, we're looking at outcomes, and you're going to do this prior auth, and you're going to go through this department, and it's going to make healthcare more affordable. The average amount of time spent on authorization for one patient is 9 hours. How is that cost effective? I mean, 9 hours in my day, I can accomplish a lot usually, but if I'm on one patient for 9 hours, that means 5 patients a week, if that. Not very cost effective. Some cons: provider burden, negative patient access, barrier to care. So what's interesting about Texas is there's this legislation that's coming out that if you have had a certain percentage approval rate of your prior auths, you get this gold card. And so you don't have to have a prior auth now if you've had so many go through in the past. Kind of cool. I want to see how it actually works, because my fear is, yeah, you got all these approvals, you're not doing PAs. How many claims are they going to hold on the back end and ask for medical records? Or my next favorite, they're going to be like, send me your medical records, but don't send them electronically. I want you to drop them in the mail. Then I don't have proof of timely filing because a stamp doesn't count. So that's always fun. So some different types of utilization management that we come across: step therapy, prior authorization, predetermination, advanced benefit determination, medical necessity review. I like to encompass that all in one title and call it pre-service review. This wraps in benefits, it wraps in whatever type of insurance approval you have to get. I think that's one of the most common things that I find in any education I give is everyone knows it as prior auth, but a prior auth and a predetermination are very different things. Understanding that difference, understanding the different submission methods, very, very key. We'll talk about some more of that in a minute. Some best practices: complete all necessary paperwork. Please check the right boxes. Please put, if there's a middle name required, put it on there. If there is junior, third, whatever, fill it all the way out. Your orders, your prescriptions, especially those hub forms, referral information, and the insurance required information. I love when I see a form, it's got the patient's insurance information, and it's like ID, group number, RX bin, PCN, right? You've got the ID, no group number, and like one of the RX. And you're like, what am I supposed to do with this? I need the rest. Provide thorough documentation. Cough, cough to my providers. Clinical history, labs, radiology, other procedures, medication history. I've been very spoiled in my career to work very, very closely with physicians. And one of the first things I love to do is say, let me see your notes. Like, let's talk about your patient, okay? And I'm in the world of biologics, right? So I love when I see a follow-up note that doesn't mention the biologic at all. How am I supposed to authorize a drug that you didn't say they had? So I make what's called a physician cheat sheet, and I give it to my doctors, and it says on a new patient visit, I need to see this, this, and this. On a follow-up visit, you have to mention in your subjective, in your assessment, and in your plan. I need to see it everywhere. Patient states, blank is working well for me, or if it's not working well, why isn't? And what clinical decision are you going to make to go with it's not working for them? Put that in your plan. I can then work with the insurance company to say, hey, he wants this 3 more months to see if it's going to work. Educate patient on the process and their responsibilities. It's not the Walmart mentality of every customer is right. This is a little bit different. Patients require, I don't like to say hand-holding, but there's a degree of that. But patients deserve and need education on this process. It's not simple. Some of these drugs can take a month to get approved. Some you get in a day. But setting that realistic expectation with the patient, talking to them ahead of time, like, hey, I'm going to fight for you. I am your advocate. This could take 3 weeks. I promise I'll give you a call. If you get a 1-800 number calling you, please answer it. Just by being honest and being forthcoming, and hey, hopefully we're under promising and we over deliver, right? Like, oh, it was really only a week. But by doing that, the patient has that open relationship. So if they do get a call from 800 number, hey, they're calling your practice. Hey, I got this call. The pharmacy says they're ready to ship. Cool, I hadn't heard from them. Now I can go back and do my part of the job. So a little more on pre-service review, since it's all encompassing, right? From prescription to administration, many things occur simultaneously. I have tried to write out medication access on a timeline a million times, and there's too many things moving all at the same time. So you're getting the prescription, you're getting your benefit investigation, you're selecting the correct benefit. There's a lot of practices that don't understand the difference in medical and pharmacy benefit. So they're like, give me everything. Well, that's confusing too. White, brown, or clear bagging. If you don't know those terms, we can talk about that later. Authorization or other types of insurance approval and delivery of medication. Are you buying it? Or are you getting it from a pharmacy? So what are some next steps? Obviously, have your preferred method of acquisition. If you know me, you know I'm a buy and bill kind of person, so I know where I'm going with it. Medication. How does the patient get it? Is it infusion, injection, oral, and site of care? Not talking about payers, but there's a certain payer that did a really wonderful, not so wonderful, site of care policy last year. Really was tough. Manufacturer assistance, right? I'm very pro manufacturer forms. I love my hub enrollment forms. I lean on my FRMs like there's no tomorrow. So I make sure I've got my patient's authorization signed. I make sure I've sent my forms in. The BIs, right? A benefit investigation, you have to keep in mind. You're only as good as the rep you get on the phone. But the more cases and examples you have of a BI, the better your chance to fight. So if a manufacturer is going to do that, and then I'm going to check on mine when I call, and I have two different answers, something's wrong. I need to go back and double check. It's a great way in the process to protect yourself later. And then copay assistance. The whole goal of Healthcare Advocate Summit and NMAPA is to change the script, especially on copay assistance. Usually it happens after the patient gets a bill, right? Sticker shock. Oh my gosh, I owe $2,000 for my drug. Well, let's put copay assistance in much earlier in the process. Let's have those conversations with our patients so that if they do get a bill for $2,000, they're not calling you mad or scared. They're calling you say, okay, I remember you talking about this. What are our next steps? Again, that communication. And then the good old insurance part of it, right? Eligibility, is it a carve out somewhere? I love when I use the word carve out and they don't understand that, but keep asking. Step edits, formulary changes, different types of requests for coverage. Voluntary versus required. I love voluntary. I do it every time. Yeah, it's more work, something else I got to follow up on, but it shows I took that step. So if they try to hold me up with medical records, I'm like, I did the voluntary stuff. Pre or post service, and then those can carve out. So what else, right? I'm a buy and bill person. That's what I teach. That's what I know. But that may not be a practice or facility's preference. So how do you work with them? How do you teach them? How do you talk about other options? Most commonly in the private practice world, you see someone start a patient on a medical benefit drug, their Medicare. Comes back, has to be buy and bill. Well, I don't do that. What do I do now? Explaining alternate sites of care and so on. That can get a little confusing too. And then telling a patient, hey, I know you see us, but now I'm going to send you here. Some other typical barriers. Holidays. Holidays aren't bad. We all like a day off. But holidays and medication access can absolutely derail the process. And then, of course, everyone comes to the doctor in November, December. We're getting ready for Blizzard. It's re-verification season, and I need something approved. And then, oh, my doctor wants to take off 2 weeks in December. Who's going to do my peer-to-peer? Local and regional payers plus Medicare, really knowing your local plans. Going back to being able to choose what benefit you want something on, you got to know your payers, what they prefer. Payer policy criteria. When I was doing auths full time, my claim to fame was I was kind of a Rolodex. I knew my plans. I knew their exact criteria. I could tell you every lab value, but it made my job so much easier. So when I read a clinical note, if my doctors followed their cheat sheet, I'd have it all right there and say, yes, this one works. No, this one doesn't. So if you don't know your local payer policies, Google, dive right in. And then where to request. If you can't find a policy, if you can't find a reimbursement or a fee schedule, what do I do? Where do I go for that? I always say Google's your first place to start. If not, your manufacturers have employees that partner with payers. Ask for them. So just because you don't get what you want from a payer, this is what I see too. Just because you don't get what you want, don't just be like, hey, I need to talk to that person. Hey, can they help me? Can they answer some questions? There's a really great relationship there they have with those payers. Ask questions. See if there's someone else, or if you can have a chance to write a letter. Doctors love to be like, I need to talk to that payer person. Just hold on. We'll get there. So let's talk about denials, right? Because they're everyone's favorite. I'm going to show you something in a minute. I'll go ahead and skip to it. So this is my favorite video of what it's like to be in medication access and you're trucking along and then all the wonderful things happen. How many times have you felt that way? You're going, you're doing something, and then boom, you're just done. For the record, that was my son, and he was perfectly fine. So, 2-year-olds in Taekwondo, that's what happens. But so you get this denial, right? You've worked so hard, you've gone through all this stuff, and it's like, okay, this isn't happening. Read it carefully. A denial is not always a denial. Sometimes it's a, we need more info, but it looks like a denial. I've seen plenty of times in a chart, this is denied, I'm done. All they needed was a lab. All they needed in our space, a PFT set or something like that. So maybe it needed to go to the medical benefit, but it was sent to the pharmacy benefit. Okay, again, not a denial. Let's go over the medical benefit, submit there. Incorrect provider ordering or servicing, right? Sometimes you put the ordering doctor as Dr. Smith, and that Dr. Smith was supposed to also be the servicing, but somehow a pharmacy got added. Well, it's not a denial, it's just the wrong way you're supposed to do it. Incorrect dates, incorrect units. I see it a lot when we do these portals to submit prior auths. I'll request 13 for once a month. Well, they'll deny me because it's supposed to be 12 for a year. Technically it's 13, but fine, I'll correct it. Diagnosis codes, that trips everyone up. Incorrect infusion times, and then missing concurrent therapy, especially when you get into the combos. So you've read this appeal, or you read this denial, you're checking it twice, what do? So if it really is truly a denial, what are your next steps? Appeal. That lovely little appeal letter, or even a denial letter, what are you gonna do? Most of the time you have a time, right? You have 30 days to appeal that. If you go above that, you gotta start all over. Sometimes it's worth waiting. I don't recommend that, but especially in situations where you had to pull journal articles or something. Sorry, I got talking fast. And then how much time do I have? Peer-to-peer is usually a lot faster in my experience. If I can get a provider on the phone with another provider, I have a better success rate. That doesn't always happen. Sometimes they're booking out 2 weeks, sometimes my provider's out. So if it's just a letter and they'll have a decision in 15 days, sometimes I'll go that route. So when you're building that appeal, again, back to that peer-to-peer. One of the first things I always ask is, does it have to be my doctor? There are payers that will allow nurses, pharmacy techs, MAs to complete that peer-to-peer. So always ask, because I know I can read the patient's chart. The doctor is way more knowledgeable than I am, but I can read you those facts. And sometimes it comes down to, I've done these peer-to-peers, right? I pull the payer's policy and then I pull the patient's note and I say, okay, you say the patient has to have this. My patient has this. And I've put this in letter form when I'm feeling real petty. I'm sure they love opening those. Listen, you do what you got to do to get an approval, right? Especially, gosh, one of the drugs that I cover, I know it forwards and backwards. It's been out on the market for a really long time. I can tell you exactly what it is. So just match it up. I really want to put at the end, thank you, sincerely, Elizabeth Johnson, P.S. Try me. I haven't done that yet, but I'm thinking about it. Make sure the provider has all the pertinent information when you're doing a peer-to-peer. It's great. You scheduled it. You gave the doctor's cell phone number. You know he's going to get the call or she. But then how does the provider know what you submitted for the prior auth, right? You could have submitted stuff from 3 years ago. You could have submitted stuff when they saw another provider in the office. How are they going to know that? So make sure if you're doing a peer-to-peer, you have it well documented or a nice little packet to give them of like, hey, this is what I sent. These are the important parts. Sometimes you highlight, you know, do you ever have to highlight things for your physician? Just, here you go. This is what I sent. Schedule it on a day, time, and phone number that will be answered. The worst are the lunchtime ones. Here's the office phone number. You roll your phones at lunch, but you didn't give the back line. So they'll leave a voicemail. You got to reschedule. Could be a week later. On your appeal letters, when in doubt, track down a template. So manufacturers, when you're on their websites, there is oftentimes a support or resources section. If you're not familiar with the drugs that you cover, I strongly recommend going to those websites. Make sure you're on the For US Healthcare Professionals part. There's usually a patient section and a healthcare section. Go to support resources. Most times there's a reimbursement guide. There are obviously patient assistance informations, but a lot of times you will find a template by the indication or disease state to appeal these letters, or there's a medical necessity version. And sometimes in the appeals ones, it's, hey, I got a denial, I need to get this overturned, and it's not quite what you were trying to explain or do. So I love the medical necessity letters because usually in there is verbiage about what that drug is intended for, and that's where I go and say, hey, my patient has this. So if you haven't checked those out, strongly recommend. Also ask your FRMs. Your FRMs will have great ideas where to go, what to do. Let's see, if not Google, just be careful when you Google templates or Google anything for a drug, because the internet is pretty big now, in case anybody was wondering, and things that are outdated could be there. You always want the most up-to-date versions and forms. That's why I say go to your manufacturer websites. Tell the patient's clinical and personal story. Quality of life is super important. I work in the asthma space. If it is hard for that person to go from their kitchen to their mailbox, and that causes them to have a flare, that's an important activity of daily life, okay? Goes in my letter. Hey, this patient struggles with this. This drug could benefit them in this way. That's really great. I'm not saying grandma died, this, like, it's not a drama soap opera, but quality of life is really important. Back to my being petty. Include a copy of the PI and/or policy, especially when a new indication for a drug comes out. Again, going back to my space, there's a drug that has probably 4 or 5 indications now, and the insurance hasn't always kept up. They haven't loaded it in their system, but I still need that approval. So here's your PI, take a look at it. And then you can always ask your patient or caregiver to call or to write a letter. Patient letters speak volumes. And I understand that's a lot. It's a lot to ask for a patient. They're probably going to have to go home and write it, then come back to the office, and who knows if they're going to drop it off on time. But something I said earlier, right? You've had that conversation with the patient. You've educated them on this process. If you call them saying, hey, I'm trying, but I've got a denial, I need this letter from you, that open, honest communication, I bet you get your letter. Most patients that I've worked with in this situation, I have a letter the next day. Sometimes they scan it, email it to me. Sometimes they drop it off, but it does make a difference. All right, poll time, okay? What is your preferred method of appeal? Show hands for peer-to-peer. Okay, what about letters? Most people default to letters. Okay, cancel and start all over. Sometimes that just works in the situation. What's another, is there any other way somebody will submit an appeal? Y'all don't leave me up here without answering. Come on now. Yes, you can. That's a great one. I'm on buy bill side, so I don't do much with that, but yeah, there you go. Claim denials, right? So we've gone from all the work we do before to now the patient got their therapy to we're on the other side of it, right? So now you've done all this work and then they still won't pay for it or something happens. Or in the pharmacy world, they're not shipping the drug because at dispense, it doesn't go through. Really common mistakes happen. And I know computers are great and I know everything's automated nowadays. Sometimes things just don't work. So you get a claim denial, immediately check for these common mistakes. Incorrect number of units. Maybe it did pay, but it didn't pay enough. So go back and look. Did you bill out the right number of units? Incorrect CPT or HCPCS codes. Then when you talk about the bundled codes, especially on your infusion side, maybe you needed a modifier or something else. Incorrect diagnosis, modifiers. Incorrect carrier selected. This has tripped me up more times. I originally wasn't a biller, right? Go back to, I was a nurse, clinical minded. Somebody said, enter some claims. I'm like, okay, I can put some charges in. It'll be all right. I didn't realize back in the day, Medicare and a secondary, like it filed to Medicare first, then goes to the secondary. So I would just pick like, AARP and file that out. Whoops, not the right way you do something. And then incorrect fee schedules. Sometimes a provider hasn't updated their fee schedule in a couple of years. Go back to your contractor provider service relations and talk to them. Or their billing fee schedule, which is another bullet point I should have put, is if you're new to buy and bill, many times marking the price of the drug to bill out to capture your full allowable, that's not understood. It's a very common error as well. So on these claim denials, NDC codes, knowing which payer requires NDC billing, and knowing what format to put an NDC in, right? 542, there's all kinds of really great PDFs out there that help you walk and change those. Diagnosis codes, if there's a 0, if it's something 0.10, make sure you got the full code on there. Let's see. And a lot of these drugs now, right, they're approved for multiple indications. The problem that I see the most is putting a diagnosis code for not their primary indication. Make sure you are putting their primary diagnosis, list secondary and tertiary and so on. Make sure that's appropriately recorded on your claim. So I'm from the private practice world, so I'm using a CMS 1500 as an example. The prior authorization number. So box 23 on a CMS form there, you can put your prior auth number. That goes a really long way. I know it's an extra step. Some people try to throw it in box 19, which is additional. Put that in 23. It literally says prior authorization. Have it in there, because a lot of times claims deny for no prior auth because nobody opened another window in their system and took a look. Box 19, I like to put drug explanation more so there than prior auth to explain what I billed in that appointment. The other thing you will see on an EOB that comes back are these ANSI reason codes. Has anybody heard of the ANSI reason codes before? Most of us have. I had it when I started, so I learned very quickly. CO45, I pretty much ignore at this point. Back to that fee schedule thing. So these are some of the most common ones you see. These will all be on swap card at the end, so you can go back and take a look. The ones that will scare me, and I don't like to see on there, is the CO15, payment adjusted because the authorization is missing, time limit for timely filing, and then non-covered services. So this CO50, is anybody seeing that pop up a lot right now? The non-covered services? That's killing me, but it's coming up a lot. And there's one payer specifically that it keeps coming up with. And then the non-covered charges. That's usually something to do with diagnosis as well. To appeal or not to appeal, I will fight for every penny. So I'm always appealing. But again, that depends on staffing time and so on. So submit a corrected claim. There's a difference in an appeal and a corrected claim. So you've gone through, right? We talked about all the things that could be wrong. You've gone through and it's like, oh, this is simple. I'll just submit a corrected claim. Yes, you are pushing it out 45 to 60 days to payment because they have to re-review it. But that's okay. You fix whatever the minor issue was. Appeal, it's going to take a little bit longer. So I have escalated appeals up as far as they can possibly go. I've taken them to outside companies to review. I've gone all the way up through the insurance commissioner. All of my claims have been paid because I'm not going to give up on that. I had an injectable medication that I fought 2 days of service for over 2 years. The insurance commissioner, it was in one state, patient had insurance from another state. So I had 2 different insurance commissioners working on this. It paid. But going back to my BI, I had 2 BIs. One I did, one the manufacturer did. I had my prior auths. I had everything. This was a carve out to SP and no one caught it. They paid. So on the appeal, have all of your stuff, that packet, maybe you gave that to your provider for their peer-to-peer. You got everything. That's the basis for your appeal. Start there. Sometimes they deny for no authorization. This can be a really great opportunity. If you had to hurry up and get this patient treatment, do not recommend this. me put that disclaimer out. Maybe you rushed through, you got your prior auth, or you didn't get your prior auth, but the patient got drugged. They still needed a prior auth. At this point, after your claim denial, sometimes, if you're lucky, depending on their policy, this is when you can ask for a backdated authorization. There are certain payers that have a 30-day window. They will go back 30 days. But if you've had an issue, right, say you had to do correct units first or something like that, you could be past 30 days from your administration. So just be really careful with that. There's no harm in ever asking, right? The worst they're going to tell you is no, and feel good, but always ask. Medicare denials are my least favorite, but important to talk about. Locate the auditor dedicated to resubmitting the claims and appealing denials. If you just pick up the phone and call Medicare, chances are the person you get on the phone is not going to exactly know the appeals process. So make sure to ask for someone that does. And if they don't know, I always feel so terrible saying, can I talk to your supervisor? But ask for someone until you get someone on the phone that understands that process, because just to drag it out further and further because someone doesn't know, not great. So just ask. Most Medicare Advantage plans do require a PA. Make sure you know the difference. And the next talk we're going on is about Medicare. So if you want to learn more about the parts of Medicare, super important to know when you're doing this. Supplements or Medigaps don't usually require a PA. There's this new thing out. I don't know if any of you have seen it. So I'll have a patient with AB and they've got a supplement. It's a Plan F, but it's an HDF. Has anybody seen that? I know you have. So HDF is a high deductible Plan F. So it's still 80/20, but it's not the $202 for Medicare the patient meets. They have a $2,500 deductible to meet on that Plan F. So you want to talk about assistance and grants and all those things, whole separate ballgame with that. So watch out for those letters that are popping up. Medicare Part B and supplements could do retrospective audits. I do not buy and bill off-label. Audits are a real thing. I've had audits come back to see if my provider was in the office that day, or if I had a locum tenens, things like that. Audits happen, and I always want to be prepared. So everything could be fine and dandy. You never hear anything. Next thing you know, you get a stack of paper from Medicare. They want to know everything about a patient from 3 years ago. Make sure you always have your stuff. Additional documentation requests, ADRs, 120 days to submit all that, records, so on and so forth. Office facility has to appeal that. And then Medicare may recoup money for lack of medical necessity. Again, going back to on-label and the documentation part. Additional support, my favorite part of this whole process. And I'm still doing well on time. So manufacturers, I said earlier, I am very pro manufacturer support. And that comes from being anti-manufacturer support. So when I originally started, I worked with a physician who didn't like reps in his office, would never do lunches, kept the door shut. You were lucky if you had my email address. And so it was purely trial and failure. The nurse that retired from the practice was 50-ish years my senior at the time, handed me a binder for one of the specialty drugs and said, here you go, my last day's tomorrow, figure it out. No education, no, hey, this is how it works, no list of patients that were already on drug, figure it out. So I made a lot of mistakes. I lost a lot of money in buy and bill. I didn't know who to talk to at pharmacies. I had wrong benefit authorizations, but I figured it out. Had I had my FRM or my sales reps or my contract managers, had I had those people, gosh, I could have made a lot less mistakes and been a better advocate back then. And we're really focusing on reimbursement and access here. Your field reimbursements, if you don't know who they are for any drug in your practice or facility, find them. If you don't have one for a company you see here at this event, ask them to connect you because they're your lifeline, right? Field reimbursement knows the programs, knows the access, can usually talk HIPAA with you about that patient, and they know your local and regional payers. So let's talk about the challenges. Let's talk about the barriers. Have them there. Hub services, right? For good or for bad, everyone has a different opinion on hub services. I love them. I love them because they're knowledgeable, they're experienced, and I can pick up the phone and call them. If I've done all my paperwork and my enrollment forms, they're incredibly helpful. If the patient has signed their forms, even better. And if your patient hasn't signed the forms, A lot of them now has text message. They'll send a link to the patient, but you have to communicate that to the patient so they know it's not some scam. And then other access programs, starter kits, denied patient savings, affordability, all have different names. By show of hands, how often do you think about those access programs? Every day, once a week, once a month, or do you plain forget about them? Every day? Okay, well, here's my truth. When I was doing this every day, I got so caught up in, I'm going to get this authorization, I'm going to get this approval. Oh, I got a denial, I got to appeal it. That I'm so hung up on the process, I forget about these other things. So I could be starting my patient on drug while I'm still fighting it. Those access programs are huge. And if you're not familiar with them, please, please, please ask your reps. They're incredible. And I see it a lot with buy and bill practices, right? We're just ready to buy the drug and give it. But in the meantime, we could have that patient on therapy. And no, that's not really an argumentative point in prior auth. Usually it has to be 6 months before you can use it. But you have that. Patient started therapy, I need to continue. Grants, these are great additional support. I knew nothing about grants and foundations when I first started, and I still don't know everything. I'm learning so much. But go beyond the traditional search, right? Don't just rely on Google to tell you who has funding, who doesn't. There are solutions out there. Find your phone a friend here at this event. Hey, do you know where I could get coverage for this or what's going on? Look it up by disease state. A lot of times, so my dad had Parkinson's and needed a lot of different costly medications. Wasn't my area of specialty. So NORD, the rare disease organization, actually had really great information that went out for Parkinson's. But I didn't find it on the manufacturer's website. I didn't find it on any of the grants websites. I found it there. So break the traditional search of like, I'm going here, and look everywhere. And encourage patients to seek local opportunities, health departments, state programs, benefits counselors, senior services, especially your Medicare population. There's a wealth of support out there, but most don't know how to access them. How many of you have been doing an author in a situation where the words low income subsidy comes up? Can you explain low income subsidy? I couldn't at first. So you know that you can sign up to register patients for low income subsidy. I just learned about this recently. But in that situation, pharmacies used to help register patients for that. They don't always help them now. So now you're saying, hey, go down to your local Social Security office. Well, guess what, COVID? Social Security offices aren't open. So what's your patient supposed to do? Right? They're not exactly going to hop on Google and find it. So network, connect, call your local health department, but have those resources available as well. To talk a little bit more about the levels of appeal for Medicare, right? There's lots of levels. Most people just go to 1 or 2. What's the highest level you guys have been to? Anybody been all the way to 5? 4, 3? Usually 1 or 2 is like the most common. If you're getting way up there, you're really fighting hard. Most of my appeals are on the commercial side. Haven't had to do too much with Medicare. So on the commercial side, internal, external, usually is about the gist of it. And internal, it could go through 4, 5, 6 different reviews. External is usually 1 or 2. The plans that will get you that you're like, oh, I'm gonna appeal this. Well, employer-sponsored plans, because the employer can have an impact on that. No offense, but AT&T, those are the hardest insurance plans for me to work with. Federal plans fall under a whole different category, especially your civilian workers, right? They look like commercial, but they aren't. There's different rules. And then self-insured. So beyond your marketplace and all that, small business, I have my own plan, that's it. Copay cards and appeals. The number one thing I see is getting caught up fighting an appeal and not sending the original data service or EOB to the manufacturer or copay card company, so there's no record of the data service. You have to be able to prove when you gave that medication. If it goes past 180 days or whatever that term is for that program, oh well, you can try to appeal it, but usually doesn't work. So when I teach buy and bill to offices, even if your EOB is incorrect, even if you have to refile something, send that EOB that shows your date of service so that the manufacturer or copay support has record you injected something that day. Put a little note on there, have to correct this, waiting on determination. But so they know you gave it, then it's on record. Sometimes it takes a few steps, right? But just send it on over. Each manufacturer or card processing company has a set allowance. Again, make sure you follow those. Federal program beneficiaries cannot use manufacturer financial assistance due to anti-kickback statute. Record keeping, again, submit that EOB. And then I'm not really a paper person, so I scan everything in, but I usually have a folder of EOBs I'm working on my network. And so I'll just put, pending or incorrect unit, something, so I know I've submitted it, but I don't have to go back and fix that. And then my favorite, top 10 tips that I have, and then we'll do some Q&A and kind of chat about this. But everything takes time, right? Just make sure there is enough time allowed, i.e. timely filing. Patience is a virtue. I'm pretty sure all of our parents have said that to us at one point or another. So it makes us great advocates, guys. But just make sure you have enough time when you're doing something. Mistakes are easy to make with coding. Know the codes and code types. I love calling a payer and saying, I got a HCPCS code I need to look up. They're like, I'm sorry, what? I'm like, HCPCS? It's a J code. I'm gonna give you a J first. Mistakes can be fixed, but be aware. C number 1. If you make a mistake, you gotta have enough time to fix it. If you are unaware or unsure, ask, right? It is more helpful to ask how to submit something than keep submitting it incorrectly. Going back to I'm spoiled rotten. I have a group of friends in healthcare that I call my phone of friends. I have this drug, I have this payer, what do I do? I can reach out to them. Kenny and Jordan in the back. How many times have I texted you saying, I have this drug or this, I need help with it? Find your people, find your phone of friends. We work together roundabout way. I'm here for you guys, but it's made a huge difference. Even my field reimbursement managers. Most manufacturers have multiple portfolios. If you have a question, maybe an infusion center, ask them to connect you with someone. That way you can get the help you need. Be aware of payer policies and their medical criteria, kind of self-explanatory. There's an ICD-10 code for everything, but only a select few that a medication is actually approved for. Know your ICD-10s. Authorizations and predeterminations are incredibly important, including the voluntary ones. Sometimes an appeal isn't required. Correction and resubmission is all that's needed. Hub services can be your best friend. I've always worked for bigger practices, so I love to be like, who's my direct contact? Who can I talk to? Who can help me? They're like, Elizabeth, just call the number. Someone will help you. And I've never been steered wrong in that situation. Network, connect. What I've said a million times in this presentation. Someone, somewhere, has experienced a similar situation. What they did, what they learned, how they overcame this is really important. When FRMs are going through training, and I've been lucky to be involved in a lot of FRM training, we talk about all these once in a lifetime what if scenarios. That's the whole point, right? What if they come up again? What if this payer changes their policy and this starts happening a lot? So always bring it up, always escalate it, because what you see today, someone may see tomorrow, and then they've talked, you've talked, and all of a sudden there's a solution. So if you fought it for 6 months, maybe the next person only fights it for 3. You can make a huge difference just by talking about those things. There are some references in this slide deck, more so about the Medicare stuff that's in there. That's it, guys. That was a lot of info quickly. But questions, let's talk about this. Kenny, since you're back there, what's the longest time you've held on the phone for a PA? Oh, you beat my time. That's always an interesting situation to get in, right? When you're three-weighing or bringing together multiple, different companies or, oh gosh, yeah. Any questions for me? Yes. I have all kinds of handouts I can give. So that's actually my favorite part of what I've been able to do. I have a lot of favorites. I love prior auth, but working for a large allergy group for so many years, I've been able to see how it works in probably 100 and something different locations. And then I became a consultant and went outside of my practice I was with and worked with lots of others. And so I've probably been in a total of close to 400 different practices. And I can tell you there are the general ways to do something, right? And I hear the same things all the time. We don't have enough staff. We're really good at this. We've never lost any money on drug. And our SOPs are tight. Okay, let's look at all of those things. And it's not something to just close the door on, right? It works differently for everybody. But my top things that I always talk to a practice about is fee schedules, understanding how to get them, understanding how to set them. That's more of your practice management provider side. But on your biologics coordinator, advocate side, knowing your payer policies, knowing your plans, and knowing how to submit to those plans, right? I have a lot of people that hold with Anthem, for example, for forever. Well, Availity, go to their portal, utilize those different tools. Manufacturer portals, a lot of people still handwrite forms. You can do a lot on those portals now. So making sure you understand that. And I love a buttoned up SOP that can be given to everyone in your office, has communication chain on there, who's working your biologics, who's doing your billing, who's going to do copay cards. You spell it out. You spell out the responsibilities. That way, if a patient calls, front desk answers, I have a copay card question. I know exactly who to give it to. So you improve your patient and customer service relations, but you also have this well-defined process in your office. Everyone knows who's kind of doing what, but also everyone knows what those steps are, so that if somebody has to leave the practice, God forbid, or they quit, you know exactly what's going to be missing, and those and the other steps of the process can step in and cover so you can fill that. So it's making sure you understand and communicate those kind of things. We can talk about the nuts and bolts of buy and bill at any time, but without that key piece, it doesn't run. Anyone else? But thanks, everybody.